It has been a busy week, John, and we usually get a respite in this time of August, but things have really continued to move on and heat up, and I think it's going to be a wild September.
One would guess.
Good. Well, why don't we go ahead and get started? Welcome to everyone who is logged on, and we expect a few more as we're going. This is FX Camping. I'm an internal medicine physician here in Boston and the principal lead for digital health for MITRE. And we have gathered now for our 23rd week in a row for our Healthcare Coalition Response Series. We have a tremendous lineup of speakers, panelists and speakers today to discuss the topic of social inequities and the COVID-19 community response. Before we get to the panel discussion, I would like to introduce John Halamka to you, and you've met him in many weeks before. John, you continue to bring out your many skills, and we just heard about your chainsaw work. But bring us up to date. You're a person that can't be put down. So tell us what's going on.
Well, so what's so important for all of us in this time of COVID is to be agile. So whether you're dealing with a political conflagration or a natural disaster, we just face every day, one day at a time. And so the topic of the week, of course, is that on Sunday evening, you heard from the commissioner of the FDA and the head of HHS and from the president that the expanded access program, the notion of making at least compassionate use of plasma in certain circumstances available, will be replaced by the emergency use program. The notion that any doctor who feels that convalescent plasma would be an appropriate therapy could prescribe it without having to go through the government paperwork and what were the many steps of the EAP program. The controversy, of course, is that the safety has been clearly demonstrated in multiple studies and papers, but the efficacy is still a work in process. And I'm sure you've read many articles in the press about this. The question is, since there wasn't a control group, there wasn't a randomized controlled trial, what effect did it have on whom? And in the chat window, FX has posted the EUA. And this EUA is quite detailed, and it actually evolved over time, FX. I don't know if you noticed that, from what was originally released to what is available now. And it's quite clear that says, if you have a patient that is under 80 years old and has never been ventilated, and you give them high titer convalescent plasma within 3 days of their diagnosis, that there is a relative improvement, not an absolute improvement, but a relative improvement that is probably strong efficacy for that subset of the population in those circumstances. So anyway, just recognize that whether it's the COVID-19 Healthcare Coalition or the Fight Is In Us, we are all following the evidence and the science. And the fact that we've gone from EAP to EUA does not really change the importance or the cadence of our work. Because in fact, with the EUA, it is highly likely that there will be a greater demand for plasma and a more important need to look at controlled trials and the science and move from convalescent plasma transfusion to hyperimmune globulin and other potential therapies, monoclonal or polyvalent antibodies or other derivatives. And so we will in the next several weeks, of course, continue all of our efforts and present to you whatever evidence we find from these emerging studies and metadata analyses. So lots of discussion. It is a bipartisan discussion. I've had conversations today with both the White House and this afternoon with the Biden campaign. And it is all about science and evidence and helping the patient. And so we'll stay with that focus. I guess also important to discuss, given the topics today, are why would we consider disparities in equity and racism such important topics to discuss? The Mayo Clinic has pledged $100 million over the next 10 years to address disparities, equity, and the eradication of racism. It is very, very rare at Mayo Clinic that the Plumber building doors are closed. The last time they were closed was 9/11. They were closed to recognize the issues that we have as a country now of the tension and the disparities and the equities, and to make a commitment that as those doors are opened, that we will all be united in work to reduce disparities of care. So personally, I'm working on access to large data sets, which include social determinants of health. And so FX will be working, I'm sure, together on those to understand where there are the greatest disparities and what actions we can take to address them. So at very first, we'll build situational awareness at national scale using a federated approach to large data gathering. So lots exciting going on, and certainly FX, I look forward to hearing the panel discussion today.
Thank you, John. And thank you to everyone who has joined us, and thanks for the continued work of so many. We're going to discuss today the perspectives of a number of individuals around some of the current impacts that relate to COVID from social inequities and what is a magnified outcomes to some extent of the COVID pandemic. We have Shardai Pioche from the American Indian Health Research Center at Johns Hopkins, Dr. Aja Mondesir-Crump, who's the Vice President for Clinical Research at NQ Medical here in Cambridge, Liv Blackman, our Principal for Partnerships and Licensing at MITRE, and then we'll have two additional participants helping to discuss, Dr. Flo Reeder and Dr. Valeria Contos. So let's go ahead. I'm going to ask the panel to turn off their cameras unless they're speaking, and then we'll all come back on for the panel once the presentations are done. So Shardai, it's all yours.
Okay, sorry, I'm just trying to share my screen right now.
I don't see it yet. There you go.
Great. Can everybody see that?
Looks good.
Okay. Good afternoon. My name is Shardai Pioche. I am a research associate with the Johns Hopkins Center for American Indian Health, and I'm based here in Shiprock, New Mexico. And my presentation is on the COVID-19 response here on the Navajo Nation, specifically in Shiprock, New Mexico, as well as there are some aspects that are being implemented on other locations on the reservation as well. So a little bit about our center. Our center actually we have 4 field offices here on the Navajo Nation, and we have another office on the White Mountain Apache Reservation and in Duluth, Minnesota as well. And then with that, the COVID-19 on the reservation. So the Navajo Nation spans a very large area of land that spans into Arizona, New Mexico, Utah, and Colorado. The population is small and very remote. There's approximately 150,000 Navajo Nation members that live on the reservation. And then as of last week, we had 9,500 positive cases of COVID-19. Now, at one point during this pandemic, we had the highest per capita positive rate in the country. And then over the past few weeks, we have flattened the curve and are seeing a consistent decrease in daily positive cases. This followed by months of strict curfews, weekend lockdowns, and community commitment to wearing masks and practicing social distancing in order to take care of each other. So across the country, Native communities have been hit very hard by COVID-19, and we have seen this happen with prior infectious diseases as well. The rates of COVID-19 are at least 3.5 times higher for Native people than for Caucasian or white people this pandemic has highlighted and exacerbated existing health disparities and social inequities. And so with that, some of the health disparities and social inequities that have been made by COVID-19, especially worrisome for Native communities, and have also made the response uniquely challenging. So we have water access. About 30 to 40% of Navajo Nation homes do not have access to running water, which makes hand washing especially difficult. Isolating, staying at home, encouraging them to stay home is very hard because people do need water for their crops, livestock, as well as for homes. And so that can be very difficult. This Navajo Nation is also what we call a food desert. The communities are very remote and there's very few grocery stores on the Navajo reservation. And then poverty, we have a high unemployment rates, low education, and some of the housing conditions are very crowded. We have multi-generational families living underneath one household, which makes preventing COVID-19 especially difficult. If we have one person who had been working and had came up positive, when they bring that back home, they can infect their family, which there's usually around 3 to 4 generations that are located in the home. And I've seen it to where it's one person came home and now 15 people under the same roof are now positive. And so having to try and help support isolation has been a challenge. And then we do have under-resourced health systems as well. PPE was extremely difficult to get, and responding right away was really difficult. And then the high prevalence of underlying health conditions. We do have higher rates of diabetes, high blood pressure, some of the associated health conditions, underlying health conditions. And then we do have a high prevalence of mental health concerns as well as substance abuses too. And so with some of those health disparities, how we've, there's community strengths and resiliency that has, the community really has came together. So Navajo Nation, we are, one of our founding morals is which is family. We're very family and community based. And so with that, we are very connected to our community. And so when COVID-19 hit, we were able to collaborate, and not just families, but even with the community agencies. We are collaborating with each other, trying to find resources, helping support each other to address how we can help our community. And then also with COVID-19 and encouraging people to stay home, we have encouraged, and there's been this movement and shift toward reconnecting to your culture. So a lot of people are, really having to reevaluate, some of that culture values such as farming, hunting, access to water, and really having to look at that. And we've seen a lot more people, becoming more interested in farming and how can we, how can we improve water access? And then again, just the collaboration of agencies within the reservation really helps too. And, there is that community protective factor of wanting to protect our elders. So our elders are really sacred. They're our knowledge holders. And, we really do respect elders and we hold them in high regard. And with that, with the COVID-19, when that happened, we really wanted to really encourage staying home and protecting our elders, because this seemed to have been, they're the ones that were experiencing a lot of the complications associated with COVID-19. And then, we really try to take care of our children because, they're the next generation. And so we, I think it really enforced, that staying home because we need to protect our elders, because we need to protect our children. And I think that's when, our rates really started to decrease with that. And then the compliance with, protecting, you're wearing your mask to protect others as well as yourself. I think that was huge in flattening the curve. And what has worked well here in the COVID-19 response. So we really expanded testing. So Johns Hopkins has really collaborated with other agencies. Specifically here in Shiprock, we collaborate with the Northern Navajo Medical Center, and we assist with the testing events. So we've gone to all the different chapter houses, which are kind of community, how would you say, locations where people can go to get kind of like townhouses, but that's where they go. So we've gone to different communities, remote communities as well, and have expanded our testing toward them. We do contact tracing within the Indian Health Service Hospital at Northern Navajo Medical Center, so we've been helping with that, as well as assisting with PPE procurement and distribution. So trying to get that to our local health care resources and finding grant money or even donations that we can distribute out, as well as home support. So what we've done is through different community collaborators, we've been able to work with CORE and the World Health Kitchen. You know, we have these wellness and food boxes that we deliver to homes, especially in collaboration with Northern Navajo Medical Center. We were able to, anybody who comes up positive, we send a pulse oximeter to them, a wellness box, and a food box to encourage isolation. And then we do daily phone calls with them throughout their isolation period. And so we're able to check on their oxygen level as well as their heart rate, do daily symptom monitoring, and referral to the emergency room to get evaluated if that needs to arise. Other things that we have helped out with is a hand washing station deliveries to homes. So we've actually built hand washing stations and delivered them to homes that have addressed that they're having water access issues. And so we've been doing that. And then there also has been strict tribal policies that have been in place. So the tribal government has enforced curfews and lockdowns, especially throughout the weekends, mask mandates, encouraging people to stay home. And so that's something that has really flattened the curve, as well as health communications. There's been a lot of community education, social media, especially through radio, and Facebook has been huge in addressing those. And so I think that really has been a factor in that. And then collaboration with other responders. So, you know, again, different agencies working with each other, the Indian Health Services CORE, which is a community organized relief effort, as well as the World Central Kitchen. And so there's a lot of different collaborators, a lot of different agencies really responding to the COVID-19 right now pandemic. And that's the end of my presentation. I'm happy to answer any questions you may have.
That's terrific. I would encourage all the attendees to continue to send in your questions through the chat line so that we can then share those as we move into the Q&A section. So that's great. Thank you, Sade. That was really terrific. I'm going to ask you a question about the World Central Kitchen. It just sounds really, really intriguing. Let's go ahead and proceed with our next speaker, Ija Mondesir Crump. And I'm going to ask Ija to just introduce himself and give us a little bit about his background. And we're going to discuss clinical trials and the importance of being inclusive as we move into our next phase of the pandemic. So Ija.
Hi, thank you, FX, and also thank you, Sade, for bringing up all of that information on your response efforts and how successful it's been. I think you've actually highlighted a lot of the issues that are present across the nation right now with a lot of underrepresented communities. But in terms of my background, I will try and be brief and attempt to make myself more relevant to this community discussion. But I am a physician and scientist and researcher. I went to school for undergrad in the Boston area and then went to medical school in New York. My interests have always been in research and in changing the standards of care, making healthcare more efficient, and a focus on health policy and disparities. When I was focused on research, part of my research was in terms of developing health technologies that can reach people who are typically not focused on in the research and clinical trial settings, which brought me back to Boston and into an area that I didn't originally see myself in. But right now I'm at a health technology company called NQ Medical, which I think is doing some exciting work. We focus on digital or computational biomarkers that look at the way that people type, and it assesses the timing of how you press keys to output biomarker scores that are useful for clinical management. And so we've put a lot of focus in the space of neurodegenerative diseases, specifically looking at motor impairment in Parkinson's disease, as well as cognitive impairment in Alzheimer's disease. And so to share some of our experiences with regards to the COVID pandemic, the one thing that happened that I really haven't seen ever before was that all clinical visits shut down. And so for us to develop our product, it requires getting typing data from a wide variety of individuals and correlating that with standard clinical outcome measures. And so with in-person visits shutting down, that essentially shut down the trials that we run across the nation, and stopped research short. And so there was quite a lot of figure it out as you go, where we had to actually change the format of our clinical trials from including in-person visits to a more virtual or hybrid format. And all of a sudden, remote monitoring technologies came to center stage with a lot more interest, and focus on the quality of the data that they can gather and give to clinicians for delivering high quality care. One other thing that I did just want to touch upon briefly in these opening comments is that traditionally underserved populations, I think that there, in the past there has been, it's been very easy for issues that take the forefront to then be forgotten with the next issue that comes into play. And so with COVID, it seemed as if the issues that are disproportionately affecting certain communities, those issues also became intertwined with the nation's response and our international standing. There was a spotlight that went on to those issues, and the continued spotlight has generated all sorts of responses across the board from industry, as well as the people who are on the ground, actually in the communities, interacting with the people who are most affected. And I think it's important to keep the spotlight on issues that need to be addressed. And some of the issues that I think we're going to talk about are just multi-layered, and without a consistent focus on them, there just won't be as much progress. So I am sincerely appreciative that I have the opportunity to participate on this panel and engage in discussion with people who are on the ground doing the work, and making sure that these issues continue to be at the forefront of people's minds so that we can have innovative, ingenious responses. So thank you.
Great. Thanks, Aisha. That's wonderful. We're going to ask Liv Blackman now to come on. And Liv has been working mightily over the last many months in the C19HCC Coalition, leading a number of different projects. And she is now helping to transition some of that work into other domains of interest within the community. So Liv, I'll let you take the mic.
Thank you so much. So I'm Dr. Olivia Blackman. I oversee strategic partnerships and academic alliances for MITRE, and I oversee partnerships for the COVID Coalition with my colleague Barry Costa. and also leading social justice partnerships for MITRE, the social justice platform partnerships for MITRE. Before coming to MITRE, my background was focused on education and health disparities across the globe, working specifically in Central America, East, West Africa, and parts of Southeast Asia. I also was formerly at GW and George Mason as a professor and worked for Thurgood Marshall College Fund as the director of research. So I have some background in terms of health disparities and education, as well as technology across our global efforts. In terms of the partnerships, as you may be aware, we've had a combined partnerships of about 1,000 here at MITRE with the COVID-19 Coalition. Those partnerships have really helped to address the impacts on marginalized communities. So I wanted to take this time today to highlight those areas where MITRE and our partners have come together to inform the broader community about the impacts of COVID-19 on marginalized, vulnerable, and underserved communities. We really addressed intersectional nature of those marginalized communities to look at social categorization of race, class, and gender, which has created systems of discrimination and disadvantages. Those marginalized populations have really looked at unequal power relationships across economic, political, social, and cultural dimensions. One of the big areas that we worked on was called the Decision Dashboard, which you can find on our COVID-19. The areas that we engaged around was occupation and income disparities. So really looking at work environments, unemployment rates. We looked at educational inequalities, so access to virtual learning, food and housing insecurities, housing issues around crowded conditions, healthcare access and utilization, so healthcare insurance, lack of coverage, quality of telehealth capacity use, access to testing and services, as well as mortality rates by race and age. Our telehealth team worked feverishly with National Association of Community Health Centers to distribute patient care kits for virtual visits to augment telehealth. Those kits included at-home A1C tests. They mailed tests, home blood pressure monitors, and thermometers to those communities. They're currently engaged with other outreach efforts to add additional items to these kits and distribute them throughout those marginalized communities. Our other team has worked with the supply chain. So looking at testing deserts, identifying those areas in the vulnerable communities that have no testing sites. So looking really both at rural and urban areas and developing a white paper and dashboard to disseminate the information. Right now, we're working on academic support. So really hoping to support our minority serving institutions and associations that support those, to include Thurgood Marshall College Fund, Hispanic Association of Community Colleges, and the tribal colleges and universities. We're helping to work together to identify testing protocols and link the schools to test providers. Creating a protocol around the testing on campuses that includes locations, setup, PPE protection, and educating about how to use those tests and the frequency of the testing. We are also working around supply chain and distributing thousands of masks to communities who do not have access. We're working closely with Amy and Thurgood Marshall College Fund to distribute those masks to those communities. So a lot of people have asked us, with the COVID-19, where are we going to go from here? MITRE, we believe, is uniquely positioned to initiate, facilitate, and drive social change by examining, understanding, and disrupting systematic issues that hinder social justice, and by providing objective products and capabilities with more equitable solutions that meet the needs of all. We believe that from the COVID Coalition, we have an opportunity to bring MITRE systems view and evidence-based approach with our partners to tackle issues and design new approaches to fight social justice. In the coming months, we will work towards an approach that involves creating an environment where MITRE and our external partners to come together and leverage and share data and resources, and use MITRE as a platform on which to collaborate, engage, and further this work. MITRE will continue to broaden our scope, focusing on those social inequalities and the COVID response. We will identify multiple streams of work that can reduce systematic inequalities that affect underserved groups through the co-creation and intervention of solutions that address the root of the problem around health and social equity, communities of resiliency, and social innovation. Thank you.
Thank you, Liv. That's really, really helpful. And I've been impressed with all my colleagues at MITRE over the last year since I joined, and the ability to actually get things done. And speaking of that, I'm going to introduce to you now Flo Reeder and Valeria Cantos. So I'll just ask Flo, I'll ask the whole panel to put on their cameras, and I'll ask Flo to introduce herself, and then Valeria to introduce herself, and then we'll go ahead with the questions. So Flo.
Okay. Hi, I'm Flo Reeder, and I've been an AI practitioner at MITRE for 25 years. I am also, as of the last 14 years, a member of the LGBT community when my wife transitioned from male to female. And our experiences in healthcare is one of the reasons that I'm particularly interested in equity. We're very lucky we have the resources to overcome a lot of the disparities in terms of finding doctors and being able to drive sometimes the hour and a half it takes to get to an LGBTQ friendly provider. Others are not so lucky. 40% of homeless youth are LGBTQ, and the LGBTQ community has great health impacts because of COVID, because a large percentage of the community works in industries that have been shut down during the pandemic. So my interest is in bringing AI to this problem, which is very easy to do and hard to do well. And it really needs to be an iterative collaboration between the AI practitioners, the people who do the data wrangling, and the experts in the field from the social and healthcare perspective. And so my two main areas of interest are in looking at those next level down social determinants of health, in establishing, for instance, helping to establish better policies, better treatments, better access to resources.
Thank you. Valeria Cantos, go ahead and introduce yourself and the work you're doing at Emory.
Hi everyone, my name is Valeria Cantos and I'm originally from Ecuador. I've been at the Division of Infectious Diseases at Emory for 3 years. And my life is divided in pre-COVID and post-COVID world, like most of us. So in my pre-COVID era, my research focus was on HIV prevention in the Latino community, with a special focus on men who have sex with men, and trying to overcome the social and structural barriers related to HIV prevention and PrEP access. And then after post-COVID, I started being heavily involved in clinical trials, both inpatient and outpatient. I'm the lead co-investigator for the ACT clinical trials that test the efficacy of remdesivir for the treatment of COVID-19 in hospitalized patients in combination with other drugs. We are now enrolling for the first vaccine candidate for COVID-19, which is the Moderna mRNA vaccine. And specifically my work there, besides being a physician and co-investigator, is to inform the team on how to engage the Latino community in a way that is respectful and in a way that is culturally responsive. I've also been heavily involved with local community-based organizations here in the Atlanta area to provide easy community-based testing sites in testing deserts, like some of you mentioned, which are usually outside of the metropolitan area of Atlanta and have a dense population of Latino and Black communities. Trying again to overcome the barriers for COVID testing, including stigma, fear of deportation, pre-registration, asking for ID, all of which we know all of these factors deter Latino communities from accessing COVID-19 testing. That is me in a nutshell.
Wow. Thank you very much. So we have a lot of talent on the panel and we have a lot to discuss. I'll ask Liv and Sade to go ahead and put on their cameras. And I'm going to, the issue around the clinical trials that relate to vaccines is really a very hot topic right now. And I'm wondering, since we have so much real world experience here, if maybe Valeria and Aisha, you could comment on that, and then, but for you know, everyone on the panel, I think we certainly would like to make sure that all the communities represented are filling those trials in an appropriate way. So let's just talk about clinical trials. We really are committed to doing things better going forward, and those clinical trials are already forming, and so it's an opportunity to put action in place. So who wants to talk about that? Who wants to go first?
I can talk about that. So as you know, COVID-19 disproportionately affects the Latino and Black communities by far, not only in terms of cases, but also in terms of hospitalizations and deaths. The reasons behind this disparity in COVID-19 in these communities has much more to do with social and structural factors, including the fact that Latino and Black communities work in greater proportion in frontline jobs in restaurants, in construction. They may have unstable job situation, which forces them to take whatever they can, which not always offers the protections for their employees. We see that in poultry farms. We see that in meat packing industries where nothing is provided in terms of support and family in sick leave in case they were sick. We can talk in more details about this later, but that is directly related to the importance of involving these communities in clinical research, but not doing so in a way that they feel like they are being involved and not experimented upon. Especially in the South, there is a very well-earned distrust towards medical providers and research in general because of things that we have done in the past. So trying to dispel those myths to become us as research institutions trustworthy of these communities takes time, but it's a time well spent if we want to have more representation in clinical trials of Black and Brown communities. Historically, because the people who are doing the research, the investigators, the clinicians, the staff are Caucasians, there hasn't been a lot of attention in terms of how to translate into Spanish the consents, how to translate materials, how to hire staff for which the participants can feel connected with and feel like someone is watching after their well-being. So these are the things that need to change if researchers are really committed to engage these communities in research, in learning about the population that they're trying to prioritize, including simple things like learning that Latino communities, we have 2 last names, but we only use one of them. These things that may seem minor add up to build the trust of the community. Let me just stop now.
And I would add for the LGBTQ community, that's also a problem. When I filled out our house's census, I didn't exactly know what to pick for my spouse, because although she was born as a male, she has the hormonal load of a female and has lived as a female for 14 years. So, you know, and being on some of those kinds of medications, I'm guessing, not knowing this world as well as I should, could even eliminate her from being able to participate in the clinical trials, because she is on testosterone blockers and on estrogen. And in the gay community, there are a number of HIV preventatives that people are already on. And so looking at the adverse potential interactions between the different medications and vaccines adds a layer of complexity to clinical trials.
It's actually one of the most important reasons why we need them in the cohort, so we can study those interactions. You're absolutely right.
Yes, I would agree. I echo both of your comments and concerns. The issue of trust, I can speak personally to this. I've had family members who I've been trying to convince to participate in clinical trials for some time, and you know, the past issues still run strong, and so with that said, all of the onus doesn't fall on the patients to participate in the trials, being that it's a voluntary experience. Yes, part of it falls on the clinicians and institutions and providers. And I will say this, you know, personally speaking, it would be nice to not just see responses that come after the fact, after there's an issue. You know, when I think of trust, I think of people who, in organizations who also anticipate the issues before they start. So this issue of trust is one where we need to do all the things that were already mentioned, but we also need to be proactive in getting out there and reaching out to people about the things that they care about before they become issues. And I, you know, I mentioned before that the spotlight was on, the spotlight from COVID had brought about a bunch of good changes. And I think we need to continue to carry that torch by keeping all of the positive changes that we've seen in this COVID area afterwards, and continue to do the things that we've already been doing. But in any case, I'll pass it on.
Thank you. I was just wondering, Sharday, have you had, from your perspective, have you had any outreach from the vaccine trial teams to get members of your community involved?
Yes, actually, Johns Hopkins right now with our infectious disease team, they're getting approval through our northern agency, which is just an area within the Navajo Nation. We have to go through different stages of IRB approval. And so we do have to present in front of the northern agency, which has community representatives there. And we're presenting on the vaccine trial, a possible vaccine trial that we're hoping to implement within the next few months. And then once we get approval through that, then we go ahead and present to the Navajo IRB, Navajo Nation IRB, as well as other local chapter houses within this area. And we'll go ahead and proceed with offering a vaccine trial. That is still a possibility. It's still in the process right now, but we're hoping to offer that within the next few months.
Great.
And then just echoing what everybody else had said, you know, there is that mistrust, especially among Native Americans, American Indians, and Alaskan Natives. Just, I mean, as early as the 1970s, there was still cohort sterilizations, and there's a lot of mistrust between the term research. Research is very much a trigger word around here, and so we really do have to, you know, I think having people that are from the community offering these programs and being tied to the community, and really addressing any stigma that may be associated with that term research, and letting them know that we're here for the best interest of them, as well, and being tied to the community, involved in our community, having that community stewardship, I think is huge. And and making sure, I know that we do a great job, or we strive to do a quality job of offering, when we do informed consents, we make sure that it's in the language and that they understand. So if they are primarily Navajo speaking or Spanish speaking, then we accommodate that and get a translator and make sure that they understand what they are consenting to. And I know with the Center for American Indian Health, that's, protecting the community, Native American, Indigenous communities is something that we really do strive for.
Thank you. Another lines of questioning in the chat deal with telehealth and the ability to reach out to the communities in a way that's going to be effective to bring care, and particularly to help individuals that are in isolation because of a member of the family or they themselves. Can you talk a little bit more, Sharday, about how that's working, and any other panelists maybe talk about what it takes to do that well?
I'm sorry, can you address the question again?
Sure. The idea of being able to support individuals who are in isolation now, maybe with telehealth or other methods, because we are going to continue to have this need to have persons be in isolation or in quarantine for a period of time, and it's never easy. And there's ways to do it well, but it does also need to be in a trusting and a well-resourced environment.
Sure. So our response with that, now the Northern Navajo Medical Center, which is an IHS facility, Indian Health Service facility, there's a bunch of different agencies that were trying to respond at that time, and we're trying to find a centralized way to one, support isolation by providing a household cleaning box as well as a food box to support isolation. So what had happened is we connected with the World Central Kitchen as well as the core programs. And so what they're able to do is we set them up. There was a central location that was established at the Shiprock Chapter House. And with that, we set up a system to where they are able to deliver to them. And with that, Northern Navajo Medical Center is able to not only, they're able to submit a referral. Anytime we have a positive case or a family or household, what we'll do is we'll submit this referral down to the chapter house, and in collaboration with IHS and the Navajo Nation community health representatives, they're able to distribute out this box to support isolation. Now, IHS also does, initially when they first get the referral, they'll also deliver a pulse oximeter. They try to do it that same day. If it is later in the day, they'll do it by the morning the next day. And that pulse oximeter does measure the heart rate as well as their current oxygen levels. When we did have thermometers readily available, we did distribute out those, but we've run out of those. And so if the family does have a current thermometer that they're using, we go ahead and get their current temperature as well. So we do, with the Northern Navajo Medical Center, the Johns Hopkins also implemented it. We implemented underneath them. So we assist them with the contact tracing as well as the daily symptom monitoring call. So we do the results call with the positive patients. We're able to do daily symptom monitoring with them as well. So we're making sure, we're just seeing how they're, even just by their voice, you can tell if they're struggling or not, because you can tell when they have shortness of breath or if they're constantly coughing. If you followed up with them the day before, you can measure that and see how they're doing. And, we ask them what their current symptoms are. We get the current measurements of their heart rate and their oxygen levels, and then just kind of seeing where they're at. And if we do need to help provide additional support, like let's say their oxygen level drops below 90, then we go ahead and have them come in and get evaluated. And IHS has set up a really great system to where the people can actually pull up in the EHR ramp, and the healthcare professionals come out to them. They get evaluated while they're in the car. And then if they need further support, then they bring them inside. But if they don't, they go ahead and treat them right there and, you know, provide them with any medication that they may need, and then they go ahead and go home. So that's kind of something that the system that we have set up right now. I don't know if anybody else has any other questions with that.
It sounds like a great system, and I'm just thinking about the next step for persons that are in recovery from their COVID infection. There's an opportunity for them to actually donate plasma now for convalescent plasma treatment for another person. And so we just think about, you know, creating good systems and building trust and building a chain of care can make a huge difference. And there just, as the pandemic progresses, there just seems to be a continued logical progression of how we take care of each other from a community perspective, and how that integrates with the health system in many, many cases.
Definitely. And we just actually, the infectious disease team just started their convalescent plasma study last week. So we were able to start offering and consenting positive individuals and getting them infused within the Northern Navajo Medical Center as well. So that's something that we just started on.
Great. I want to kind of direct the same question to Valeria. You're in a urban environment in Atlanta. I'm just wondering, from the community outreach and coordination for persons who are affected with COVID, do you have that? Do you have a sophisticated a program as Charday has described?
Maybe not as sophisticated, but so in terms of clinical delivery of clinical care, since the epidemic, we switched to initially phone visits and then telehealth visit for our clinic patients. I work in one of the largest HIV clinics here in Atlanta. It's called the Ponce de Leon Center. And not only for people who have COVID, but also initially, and even now, we're trying to limit the foot traffic inside the clinic to limit spread of the virus. So the clinic, we switched to televisits. We would call them ahead of time and see, you know, we will let them know that the clinic is open, and like if they needed to come, they can come. But if they're just for a checkup, their HIV is well controlled, they don't need anything but refills, then we would do that. The Ryan White registration went also through phone visits. We switched most of our patients from home delivery of their medications, so they don't have to come to clinic. And yeah, so, you know, I'm also involved in the evaluation of the PrEP clinic at Grady, and they were doing telehealth even before COVID. So COVID created this, you know, larger need to make these services more reliable. And we're currently working on a pilot to see if we can send testing boxes to the house so they can do a finger prick for HIV testing, RPR, and then swab themselves and then send the swabs over by mail so they don't have to come to the lab to get those things done. In terms of research, we are creating, because we do have some protocols to assess people who are not hospitalized but have COVID. We have set up pods or tents outside of the emergency department so we can see them in person there.
Something that I'd like to see also as an area of research, if someone's not being done now, is, you know, the homeless population and how you seek treatment in the LGBT community HUD just passed a policy that says that people can be turned away from single-sex shelters based on how they look. And so in areas where you're already stressed and already difficult, you may not be able to get into a homeless shelter. And how do you get medications delivered if you're in a shelter? So those are some of the kind of homeless related inequities that would be interesting to research more.
Just to add to Flo and what you're talking about, we're also interested in undocumented patients, as well as access to care for incarcerated individuals. So, you know, again, we go back to the idea of marginalized populations, social disparities, and those are two communities too that there's limited information, especially around undocumented patients.
So Liv, can you talk a little bit more about are there actual projects in place, or what do you see as the next step?
Yeah, we're just trying to find data. So, you know, we're very, MITRE is very driven on where we can access data and data on information around those populations, like I said, incarcerated populations, nursing homes, as well as undocumented populations, which probably don't have a lot of data around it, but the others do. So we're very interested in the partners here that are listening to the discussion as we start curtailing into the social justice areas. Those are areas that we definitely wanted to be looking at. So if there are partners on this call that are focused on inequalities and disparities in marginalized populations, whether it be around COVID or health disparities, we're very interested in discussing that. FX, I think you're on mute.
I was just going to say, I'm putting my email in the chat in case people want to send questions or get in contact. But if any other members of the panel want to also put their email in the chat, that's just fine. Similarly, if any of the audience members want to reach out, that's good as well. Good. Ija, this idea of the remote monitoring for research, it seems like it could make research more accessible, not only for vaccine research, but to create possibility of involving many more people in clinical research. Can you just make any comments about where you see the future going here? How maybe COVID is teaching us something about how we can be, in this case, more inclusive?
Thanks. COVID has taught us a lot. The standards in the healthcare setting, FDA views on digital and remote monitoring technologies, all of those are changing, and right now, it's a very active space. What can be used and what can't be used, and I think there was a low level of companies that were developing things, and in the last 5 years or so, we've seen that number somewhat explode, and then with COVID, now they're popping up all the time. But there has been a shift from something that can simply monitor to evidence-based technologies, and those that develop their tools with specific clinical use scenarios. And so we have a very specific use scenario, and I think that you'll find that there's a range of technologies that are out there for all of the different uses that you're talking about. But there are still significant hurdles, one of which is reimbursement and getting clearance through the FDA. And I can say that my company is specifically in talks with the FDA about the level of data and the quality of data that is necessary to achieve clearance. In general, the FDA has specifically looked at different data with a very specific traditional viewpoint. fluctuations and variance is not something that is typically looked at as it's hard to interpret, you know. So the company that I work for, there's lots of variations in typing data, and we've leaned into those variations as having useful information. And so we are converting real world data into real world evidence, and there's a lot of others that are doing the same. But until there's an understanding of clinicians on how to use it for patient management, and drug developers on how to use it for drug development, you know, there's going to be a lot of interest, but it will still take some time for traction. And so,
Right.
you know, yeah. Sorry, did you
Well,
want to?
yeah, that's well stated, and I think we're learning a lot about how we can make a difference with good information, and the FDA is a great example of that. I think that's really across the board, and so I want to thank all of our panelists for participating today, and we look forward to continued work together. Our next gathering for this series will be on September 16th. That's Wednesday, September 16th at 2:30. So I wish you all a happy end of summer, and wish you all safety out there in the COVID world. Thank you. Bye-bye.